Thank you very much, Fred, and I want to thank the organizers for inviting me and to put on this excellent panel. Thank you very much. You guys have not gotten enough credit so far, so I want to send a shout out to you and also to the panel that's been, I think, very patiently and diligently working through what is a tremendous amount of material, so I want to thank you for your attention today. My only criticism of this conference so far is the total lack of Trump jokes, which I think, especially considering that it is election day, I mean, the election is an excellent opportunity to display palliative care skills in terms of breaking bad news and intensive symptom control later for exactly one half of the country south of us. With that introduction, I'll move right into the slides. I've received some speaker fees and honoraria from the following companies. I'm not going to be discussing any of their products here today. I am supported by an AMS Phoenix Fellowship as well, which helps support some of the work that you're going to see here today. I think it's important to acknowledge how many people are actually involved in palliative care education in Canada, and there's been a fair amount of work done in this area. I hope that I do that justice and represent the community involved in educating physicians in palliative care well today. My apologies if I fail to mention something important. My question was a very simple one. What resources are required to ensure adequate education, training, and mentorship for physicians providing palliative care for Canadians experiencing life-limiting illness and their families? I thought that the best way to handle this topic, rather than give you a blow-by-blow of the educational literature, was to try to organize things into a set of concepts and core concepts. Each one of these concepts either is something that is a salient concept that comes out of the literature itself, or it is a meta-concept, so where the literature is weak or where there are systemic problems with the literature and the evidence base. Why is that? So there are some core meta-concepts that don't necessarily come from specific studies, but I think are well-known barriers and issues that we face when educating physicians in the provision of palliative care. So that forms the set of 7 core concepts that I want to try to convey to you today. And I'm going to organize my presentation a little bit differently in that I'm going to tell you about each one of those concepts, and then I'm going to tell you about the implications that come from each concept as we go through. Happy to go into more depth on any number of these things, and I'm going to build on some concepts that you've already heard from Barbara this morning. I don't think I really need to spend a lot of time convincing you that this is a national priority to improve palliative care education, particularly for physicians. I think we're all pretty much there. But if we're not, certainly there was a really nice palliative care national call to action from the CMA report that was about a year and a half ago just released. And I see Jeff in the room here, so I got to acknowledge the CMA's role in calling attention to this. It follows on the set of 3 Senate reports highlighting a number of problems with palliative care and end-of-life care in this country, and physician education was a major component of each one of those. Incidentally, anybody who's good at sequences in math realizes that we're overdue for a next one, so if anybody knows a senator who's looking for work, please, please let them know that we need another one. I think there are a number of stakeholders, many of whom are represented in this room. The colleges, the Royal College of Physicians and Surgeons of Canada, which is the college that certifies specialists and subspecialists in this country, separate from the College of Family Physicians of Canada, which is the college that certifies general practitioners, family doctors. We have the Association of Faculties of Medicine of Canada, which is essentially an agglomerate of all of the medical schools across the country. We have the Canadian Society of Palliative Care Physicians. I see Dave Henderson in the audience here, who have done a lot of background work on education and is the organization representing palliative care physicians in this country, for whom education is a major part of the history, the present, and the future. Pallium Canada, Catherine Downar, and is in the audience as well, no relation to me. They've been heavily involved in developing educational material over the years, and of course the Canadian Medical Association, who I've already acknowledged. So let's go over some of the core concepts that came out of the literature. Number 1, resources. Bluntly put, there are a lot of palliative care resources available for physicians. We don't need any more. That's, I think, an important concept to get across, because a lot of times, well, let me just take you through the courses first of all. That for those who want to take fairly intensive and focused courses on palliative care, we have obviously the LEAP and LEAP 2 modules that are being developed and have been already developed by Pallium Canada. South of the border, we had the EPEC courses, Education in Palliative and End-of-Life Care, and subsets of these courses, which I'll talk about later on in another concept. But these are sort of standardized, well-recognized courses with robust curricula developed by experts and can be taught in a rigorous fashion by people who, again, are certified as trainers. People who are interested in doing more intensive courses where you're actually immersed in a palliative care environment and you want to upgrade your palliative care skills can actually go to places like the Victoria Hospice for a period of time and actually work in a palliative care environment to increase your essentially an immersive experience to increase your skills. There are a number of online resources, and of course, the Canadian Virtual Hospice stands out as sort of one of the foremost resources probably in the world for online resources availability. But of course, and I'll speak more from what I'm aware of locally in Ontario, we have Cancer Care Ontario palliative care tools that are available, and I see Ahmed in the audience here. There are formerly the Ian Anderson modules that are still available online, which are an excellent sort of comprehensive source. I mean, the list goes on and on and on. You can spend a long time listing off all of the different resources that are available, and like Barbara mentioned, there are some good ones out there. But what's the important lesson here is that we continue as an educational community, I think, to see people developing new resources and developing new resources and developing new resources. And I think on some level we have to acknowledge that this is a little bit redundant. That the amount of time being spent on this probably would be much better spent just teaching the material that's already in existence. If we simply got behind one or two standardized curricula and used them more broadly and spent all that time and energy, using what we have rather than trying to develop stuff that is largely duplicative and very unlikely to be an improvement on what we already have, I think we would probably get much more bang for the buck, if you will. The problem, and let's go to a meta concept here. Again, every system is designed to produce the results that it gets. Why is this happening? It's happening because of the way in which academic medicine is structured. That physicians and academic physicians, like all academics, their metric is impact. So what is impact? Impact is I develop something that I can say is mine, and then I convince someone else to use it, and then I see, look, someone's using what I developed, I have impact. That's good in some levels because that's a metric for an individual. But unfortunately, that does tend to generate an environment that rewards largely duplicative material or people branding something that is just a minimal improvement or a minimal change on what already exists. And considering how slowly the evidence base of palliative care evolves, it really does not justify new de novo generation of material on an ongoing basis the way that we're seeing. If you want to look at analogous situations like ACLS or advanced cardiac life support or BCLS, basic cardiac life support education courses that are out there. These are certified and recognized courses. They're a standard way to teach this curriculum. You can take a course and get certified in ACLS and learn how to do CPR and resuscitate an individual. And this is a course that is standardized worldwide. People can take the course. People can take the course to be an instructor for the course, and you get a card. And really, I think that's something where the evidence base actually advances very, very quickly, right? Where we're doing things very differently now than we did 5 years ago, and that was different than what was done 10 years ago, but we're able to keep up with this standardized curriculum. That's kind of the model that we probably should be looking at rather than this sort of diffuse model where everybody's doing their own thing. And why is that? Well, again, we have to sort of incentivize it, right? Because in today's academic environment, you don't get points for teaching other people's stuff. And so we have to recognize that's the reason that this is happening, is because the system is designed to reward it. So maybe thinking more broadly about how can we reward people. Palliative care is a little different, and the needs in palliative care to disseminate this information is great enough that maybe this needs to be treated a little bit differently than other aspects of academic medicine. So again, there's a need for dissemination and uptake of existing resources, not just focusing on generating quote-unquote new resources. Okay, concept number 2. Physicians are not being adequately trained in palliative care. And again, we talked about this already. There have been a number of efforts over the years to try to improve the way that physicians are taught, to try to increase the number of hours that are devoted towards physician and physician-in-training teaching in palliative care. And to some degree, there's been a very mixed success. So about 10, 20 years ago, there was the Educating Future Physicians in Palliative and End-of-Life Care, or FPEC, efforts, which were an attempt to get palliative care competencies ingrained into the undergraduate curricula of medical schools across the country. That was to some degree successful, and there was a team at each center that was designed to that was tasked with trying to get those competencies integrated into the curriculum. And it worked to some degree, but since FPEC, since the noise around FPEC sort of faded, there's been a considerable backsliding, and as there have been more and more pressures to teach more and more material, palliative care has fallen a little bit by the wayside in some places, to the point that a recent Dean's report just a couple of years ago found that actually the majority of medical schools, once again, are teaching fewer than 10 hours of palliative care over the course of a 3 to 4 year curriculum, which is a pretty small amount when you think about how important this concept is and the fact that we're all here today. The result, of course, is that undergraduate trainees are often uncomfortable providing it, and when they graduate, they become postgraduate trainees who are also uncomfortable providing end-of-life care. It creates an environment where there's very poor supervision for end-of-life procedures and family meetings. So one study, for example, in Kingston, highlighting the fact that, or out of Kingston, but actually involving more than 5 medical schools, and found that, you know, a very substantial proportion, I think more than a third of residents said that they had never once been observed by a faculty member performing a family meeting. Right? This is a totally unsupervised event that they were literally thrown to the wolves every single time, and they've just had to learn by themselves based on their own experiences. That's a problem, right? Like, you can imagine if somebody's, you know, doing CPR and has never once been observed doing CPR, intubating somebody without ever having another doctor in the room. You know, you think of how important these episodes are, that this is something that should be given the same pride of place as these other procedures. The other important thing to note here is that palliative care rotations, because we're trying to say that palliative care is a responsibility of all physicians, that palliative care rotations are really not mandatory in most programs, right? And often very limited availability in the past for people to take these rotations. And we're going to get to this in another concept, so I'll move on for now. But the bottom line here, you have to recognize that there's great value in recognizing the importance of palliative care teaching at academic institutions, that we've had this backsliding in recent years. We need to dial the volume back up and really get it back on the front burner for undergraduate and postgraduate curricula to be teaching these competencies to all physicians. Effectiveness. Okay, here's the elephant in the room. A lot of educational interventions are out there, and some of them have the attractive element of being inexpensive and very scalable. Others are very costly, and some are time-consuming and so harder to implement on a broad scale. But regardless of whether you're talking about small, scalable interventions or large, non-scalable interventions, we actually have very little idea about which of these impact physician behavior and patient care. I want to introduce you to the concept of the Kirkpatrick framework if you're not familiar with it. This is a framework by which many people have evaluated quality assurance and quality improvement projects over the years, but have also been applied to educational interventions. And there are 4 levels in the Kirkpatrick framework of effect. So immediate reaction of the learner. You know, I feel more comfortable after taking your course doing X. The knowledge of the learner. I know more about what I'm doing now, as assessed by some sort of knowledge test. Level 3, the behavior of the learner in a clinical environment changes. So I take a course, and then you can go to the ward and actually see that doctors are ordering things differently or behaving differently with patients. And then finally, the holy grail of the Kirkpatrick framework is the patient-level outcomes. So you actually show that once an individual has taken your course, and then you go and look at the patients that they're caring for, that person's patients are doing better than people who haven't taken the course, or that person now, the patient outcomes are better than the patient outcomes were before this person took the course. Okay, that's the holy grail, Kirkpatrick level 4, of measuring the effectiveness of educational interventions. So, you know, scary concept number 1, fewer than 1% of all education-related articles actually report level 4 outcomes. Very, very few. The vast majority, almost every one of them will report a level 1 or a level 2 outcome. Now, again, why is that? It's not because physicians don't know about the higher level outcomes. They know about them. They're just really hard to measure. They're quite expensive and challenging logistically to actually get. Measuring physician behavior on the ward is very challenging. If I do an educational intervention and administer a survey before and after, or a knowledge test before and after my workshop, that's very easy to do. But if I now have to go and hire a research assistant to go to the ward and start tracking down whoever were the patients being treated by these individuals who took my course, and then track down some patients who were being treated by individuals who did not take my course so they can compare outcomes, it becomes logistically very challenging. Far beyond the feasibility of most educational grants. So if you look at the Royal College's educational grants, they're usually capped at $20,000 or $25,000 a year, which puts the logistics and the ability to measure these level 3 and level 4 outcomes just well beyond the ability to do that. And when you think about it, if you want to think more broadly about what is an educational intervention, broadly speaking, is a quality improvement initiative. You're trying to take knowledge that you believe to be standard, and you're trying trying to upgrade the standards that are delivered to an individual, right? This is a quality improvement initiative. And a part of any quality improvement initiative is the idea that you should be continuously collecting data about what's happening in your clinical environments. And actually, that's an interest that educators have in common with all healthcare organizations, right? Healthcare organizations really should be collecting this type of performance data on an ongoing basis anyway. The fact that I have to build an entire infrastructure for quality data collection just for my one little study every single time and change the culture on that unit for a brief 6-month period while I'm collecting data, and then we go back to the way things used to be done, is a bit ludicrous. When you think that the imperative here in improving the delivery of quality palliative care should be that we have ongoing data collection. And if more healthcare organizations, particularly academic hospitals, had an infrastructure in place to collect this kind of quality data, all of a sudden, every single educational intervention that I test, or every single educational intervention that people want to roll out and try, you have an incredible ability now to be collecting routinely level 3 and level 4 data and actually knowing what is effective and what is not. So rather than dump that on the educators, and we know that's not working out, maybe this is an opportunity for these academic institutions to think more broadly about the quality of the quality data they're collecting and the outcome data that they're collecting, and create that framework that they can use to measure the quality of care delivered to the patient, that the educators can use to measure the effectiveness of their educational interventions. Anyway, I'll move on. So again, need for routine assessment of the quality of end-of-life care in a clinical environment to allow better assessment of training effectiveness. Concept 4, areas of focus. There are two big areas that most palliative care physician education interventions will address. One of them is symptom management, and the other is advanced care planning or communication around decision making. There are many ways to teach effective symptom management from the literature, and I've given you the references in the written material. I don't need to go over them here. But they can range from everything including an actual palliative care rotation as part of their training, a 1 to 2 day workshop. You can have longitudinal curricula over the course of a year or many years. There's distance learning models that have been tested. There are web-based modules where people can learn things and improve their skills. And we've even done pocket references and applications for helping people bring this knowledge to the bedside as a cue and a reminder. For teaching communication, a slightly different approach is often necessary. You can't use the same approach every time. So for teaching communication skills, learned-centered deliberate practice seems to be a really important thing. You have to, again and again, deliberately practice your skills and focus on the learner's needs. This involves feedback, sometimes small group discussion, mentorship is important. I've done a fair amount of work with simulated or real patients, but this is a major feature in the academic literature around teaching communication skills and involving workshops. If you can do them for more than 1 day, there are a few models out there. So all of these have been shown to some degree to be effective, again, albeit most of the time measuring only level 1 and 2 impact, not patient effectiveness, with a few exceptions that were mentioned in the actual synthesis that you have in front of you. But there are a number of pitfalls, and we talked about this now, that some studies have shown improvement in the desired behavior. So we teach a skill in the simulated environment, the resident appears to acquire that skill, and then we release them into the wild and then try to look at their actual patients, and it turns out that most of the studies show no effect on the patient outcomes, or in fact, in some cases, actually harm in patients and family members, which speaks to another big problem, which is that we don't actually have a universal endpoint for things like communication. How do you know whether somebody's actually gotten better at communication? There are so many different ways to measure communication. How do I dissect out the communication interaction that this resident had with the patient and family member as opposed to their global experience communicating with every member of the healthcare team, most of whom did not receive this intervention, that could have definitely colored their view of how everything was done. So it becomes very difficult sometimes to interpret the data that you're seeing. And then, of course, the other bigger problem here, which is that does patient satisfaction, if you measure satisfaction as an outcome, does that actually mean that the communication was good? There have been a number of studies showing that patients who have a falsely high expectation of life, so they are mistakenly believing that they are going to survive a fatal condition or live longer with a fatal condition, rate the communication skill of their physician as being higher, not lower. People like to receive good news, and they like the people that give them good news. So just because people are upset, I don't know that we should necessarily interpret that as meaning that the doctor did a bad job. So effective communication training obviously is time-consuming, it is costly, and it requires support, time, and resources from all stakeholders. That's a big take-home message, and if we want to improve communication skill, this is not something you're going to be able to do with a few cue cards or an app on your iPhone. Faculty development. So here we get into concepts of the hidden curriculum, which is a really important concept to understand in education. So the hidden curriculum is something that is prevalent throughout the clinical and environment and in the educational setting for residents. So what you have is that you'll have a resident who goes to a workshop and will learn the correct way to do things, the correct way to manage symptoms, the correct way to talk to patients about goals of care and CPR, and then they go back to the wards, and then they go with their staff who was educated in a time when nobody learned anything about palliative care, and they watch their staff walk into a room and ask the patient, if your heart stops, do you want us to do everything? And then they see that 2 and 3 and 4 times, and then they'll go onto the computer to order admission orders for a patient, and all the default orders for morphine and comfort care are completely wrong. The doses are wrong, the frequencies are wrong, and so it becomes much easier, and the sort of the context in where they operate, they are seeing incorrect practices. And so on the one hand, they're learning correctly for 30 minutes in a 4-year period, and then for the rest of the 4 years, they're seeing it done badly. We shouldn't be surprised when they're learning the bad skills and not the good ones. So this hidden curriculum, the sort of backsliding and erosion of the teaching material, it really undermines the problems in palliative care, because it tends to reinforce existing practices which we know are bad and why we're trying to address this stuff in the first place. If you want if you want learners to be displaying good behavior, their mentors, their teachers need to be displaying the same behavior. All of this material needs to be consistent throughout the clinical environment. So recognizing that as long as the current faculty have little or no palliative training, as long as they're not supervising and giving proper feedback on end-of-life tasks, it's hard to expect that trainees are really going to pick it up and display that behavior, right? So getting faculty development to teach end-of-life skills, and of course teaching the skills in teaching end-of-life, right? So we need faculty to be very skilled at giving feedback. So I often use the example that throughout my residency, when a staff sort of said to me, James, I didn't like the way you did that joint exam. You really should have done your joint exam better, and I wish you would learn more about your joint exam. And I'm like, yeah, my joint exam was not very good. I'm sorry. That's the kind of feedback that a trainee can take very well without taking it personally. Go try telling a trainee that their communication skills are bad. 99% of the population rates themselves as having above average communication skills. It's a trait, it's a personal trait that is deeply attached to your sense of self. When you give feedback and more or less tell somebody that communication skills are weak, you're not saying that their skills are weak, you're saying they're a bad person. Right? They lack compassion, they lack empathy. That's what they hear. So actually, unlike my rheumatologist, who was, never needed to polish his skills when telling me that my joint examination was poor, I need to have very good skills in telling a resident that their communication skills need some work, without getting them to be extremely defensive immediately right off the bat, reject my feedback, and then decide that I'm a bad person and was being mean to them. So this feedback skills, and this is a key element of faculty development that is often missing, right? So, and this, we're still in sort of the early phase of learning how to teach staff to do this, but immersive experiences for skills, so simulation as well, can be very helpful. Experiential learning and feedback. Peer-to-peer support and mentorship is a big one, right? So we have a number of models from BC that have looked at this and actually developed. Oh, can I slow down a bit? Interpreters having difficulty. I'm sorry, guys. I assure you it doesn't make any more sense in French than in English. So peer-to-peer support and mentorship are really important. So there have been published models from BC where staff in practice have linked up in networks and formed support networks for each other in terms of giving feedback and relying on each other to improve practices around end of life. And this is for practicing physicians. Again, creating an environment better where they can model better behavior and give feedback more effectively. Now again, don't blame the physicians. It's not their fault. The system is set up this way. We have too many things to do. We have too little time to do it. And to some degree, we need, if you want to change behavior, you have to incentivize it. Right, so faculty development around teaching end-of-life skills and communication skills. So the American Board of Medical Specialties, ABMS, now has, as part of their core competencies and part of your maintenance of certification, you actually have to demonstrate effectiveness in 6 different areas, and one of them is communication skill. So it is actually it is something that is an option available to colleges to be very specific about the kinds of assessments and maintenance of certification, continuing professional development that you do, that you will be, that is incentivized and actually mandated by your college that you're going to have to do this stuff. I'm getting into the 2-minute warning here. So the implications here: encouragement, incentivization, feedback for faculty development in palliative care is important. Professional development provided by all stakeholders can support innovative and effective approaches to palliative care. So this is the role for the educational community. Competency-based education. Important to understand what this is. So the classical model of medical training is the TBAG model, steeped TBAG. So I was the TBAG placed into my residency for 4 years. After 4 years, I was taken out of the hot water, and I was done. Education is based on time, and it's assumed that in those 4 years I learned all the skills I needed. We know that that doesn't work. There are people that learn at different rates, and we need to be actually doing assessment along the way. So we're transitioning to this competency-based education paradigm where there is both repetitive formal assessments throughout the training, but also with focused feedback. And then in addition to the time-based training, you actually have to make sure that you feel the trainee has achieved competence in a certain area and that you would trust them to do the procedure, trust them to perform this task unsupervised, okay, so entrustment. We are well positioned in palliative care to make this transition. So Jeff Myers has led an initiative to develop a set of 14 validated and trustable professional acts, so part of the competency-based framework, and these are being slowly rolled out in residency programs across the country. Again, following on the previous concept, the key missing part is faculty development. So none of us were trained in this environment. So our role to play as supervisors and as facilitators of competency-based medical education is not obvious to many people who do this type of education. So we need training, and again, we need skills in this area. And of course, this is also applicable to practicing physicians too, not just those in training coming up. But if people decide that they maybe want to transition or become more of a palliative type physician as they enter the final third of their career, they can actually start to get other people to observe them and say, look, do you feel I've acquired these skills? They can apply the same framework to a physician in practice that they're applying to a physician in training. So the paradigm shift from time-based training to competency-based training and evaluation needs to be supported by faculty development. Final concept: tailored palliative care education. And this is where we get into some of the key stuff from the polling, right? So every physician in Canada must be able to provide at least basic palliative care. Most Canadians say they want a specialist palliative care provider at end of life. Realistically, I'm sorry guys, but there are 250,000 Canadians dying every year. There are 500 members of the Canadian Society of Palliative Care Physicians. The math is pretty simple. That's not going to happen. But it is very realistic to accept that somebody should have access to an appropriately skilled provider. And in order to do that, we need to make sure that palliative care is thought of and seen as everyone's responsibility. It has to become a key portion of all training programs, particularly training programs that have great relevance here. Again, although a lot of people have put palliative care competencies within the listed competencies of certain residency programs, they stop short of requiring rotations in palliative care and actual experience. And that's something else that comes from the polling, saying that Canadians expect their physicians to have had experience, and their providers to have had experience with palliative care. So take, for example, family medicine training, which has a mandatory 2-month training in obstetrics and gynecology, when only a single-digit percentage of family doctors will ever deliver babies. But no mandatory rotations in palliative care when we expect the vast majority to do that. Now, many programs, I just want to be fair to the family medicine training programs, that many of them have put palliative care in as a mandatory rotation, but at the college level, it's not mandatory. When you go to the Royal College and the specialties and subspecialties, there are only 2 medical specialties that include a mandatory training in palliative care. One of them is medical oncology, and the other is radiation oncology. So it's not a mandatory training program in internal medicine, respirology, cardiology, nephrology, hepatology. In the subspecialty diplomas, advanced cardiac life support, organ transplantation, all of these are fields of medicine that have great relevance, or that would have great benefit, I think, from learning how to provide some of the basic concepts of palliative care, because a lot of their patients are going to die in the near future, and all of them are going to have symptom issues. It's hard to imagine that these patients are not going to benefit in some way from palliative care, and at least having that basic level of training so that they're not mandatory referring everybody on to palliative care. That palliative care approach that Barbara mentioned is a key thing there. So the other thing is that among specialized practitioners, those who are in focused areas like cardiology, heart failure, giving a generic teaching block to these people is probably not as beneficial as starting to tailor training towards their specific needs. So I'll give you, for example, most palliative care training is based on the cancer model, and the cancer model doesn't apply to a lot of non-cancer illness, as we've already heard about. So specialized training in LEAP is a great example. I've done a number of these LEAP long-term care, LEAP nephro, LEAP onco, LEAP emergency. I'm sorry, I'm forgetting, it's like a triple LEAP there. I'm forgetting all the LEAPs, but there are many LEAPs and there are many more in development. And I think that's the model you need to think about for some of these people already in specialized practice who really need a high level of skill in very specific areas of palliative care, as opposed to a generic sort of one-size-fits-all approach. I think you have to be involved in interprofessional training, and Barbara's highlighted that very well, but also recognizing the different role of each profession, right? That a specialized heart failure physician is going to play a slightly different role than, for example, an oncology nurse practitioner, et cetera, and do different roles. So implication, both certifying colleges would benefit from including palliative care competencies in all fields of medicine, including palliative care rotations in the subspecialty requirements for subspecialties where palliative care is particularly relevant. And in this way, palliative care education would be tailored to meet the needs of physicians in specialized areas of practice. Those were, I'm sorry I went a little bit over time. I apologize to the translators, but I'm happy to answer any questions you have. Thank you.
So thank you very much, James. There's a tremendous amount of thought and material, very, very good information for the lay panel and the audience. Just before we go to Dawn, I know I mentioned this a couple of times yesterday, and I'll mention it today. I know many people in the audience here have questions that they would like to be asking of the experts, and we'll ask for your patience. The consensus development model is deliberately designed to have the lay panel have their questions answered first. And as much as we all want to interact with the experts, we have a duty, of course, to make sure that the lay panel can ask all of the questions that they need to in order to allow for them to deliberate and to reach conclusions. But we have built into the program some other opportunities as well. So one of them was the breakfast this morning, the breakfast with the experts. Specifically at 3 p.m. today, we have an entire hour that's devoted to question and answers with the experts. They'll all be up here on the stage with me. So if you can't get your question in these sessions, we hope some of these opportunities will help, but that is the reason we're proceeding as we are. Don, over to you.
Thank you, Fred. Thank you, Dr. Downar, for your presentation. A lot to think about there. In this section, the first question goes to Marisa Lepage. Marisa.
Thank you very much, Dr. Downar, for your presentation.
Thanks, Marisa.
I think what I'm going to say here comprises a few comments, and then there may be a few questions. So in the material that we were presented, there's something that you said about improving palliative care being as much about changing the medical culture as it is about teaching skills and knowledge. So you've presented kind of this two-pronged approach where we'll be targeting education for early learners, medical students, residents, but also taking into account practicing physicians. I just want to take a step and talk about our early learners. I'm a part of that cohort. So, talking about the fact that a lot of medical schools only teach less than 10 hours of palliative care in their curriculum. You also talk about these two core competencies, so communication skills and symptom management as being important areas of focus in our teachings. I'd like to just comment on the fact that I think somewhere we should be including talking about or teaching us comfort within death and dying, having difficult discussions. Because, as much as I feel society is death denying, I think medical culture is even more so, where for a lot of physicians, death is often synonymous with failure. And I would also just bring in the point that we haven't really talked a lot about interdisciplinary teaching. And I think that that's something that's lacking in our education system. There is a wealth of knowledge that physicians can draw on from our nursing colleagues, from our social working colleagues. And I just wonder if interdisciplinary teaching should be included in our curriculums. Peer-to-peer mentorship was talked about in the context of practicing physicians, but I think that can also be applied to our learners. Getting groups of social work students together with medical students. Sometimes these difficult discussions where we're kind of thrown into the wild, as you put it, leading, trying our best to lead a family discussion where we may actually do more harm than good, lacking training in communication skills. Let's try to remember that there are experts in counseling and experts in communication within our team, within our system. So I'll get to a question. I'm just wondering if in the FPEC initiative 20 years ago, there was, I guess, mention of, interdisciplinary teaching, if there was mention of, making more comfortable our healthcare providers with death and dying, but also how much is enough in terms of training? 10 hours doesn't seem to be enough. What is enough?
All great questions. I'm going to try to do your questions justice with short answers. Your point about self-care is an important one to raise. I didn't specifically address that in my synthesis, so I thank you for calling me out on that. But I think it's an important. I think of it as a wellness skill, and I think a lot of residency programs are now required to include this as wellness in there. I would say in some ways we've done a better job at integrating wellness in some ways into curricula than we have with other aspects of palliative care, which is a bit of a shame. But yeah, certainly comfort with death and self-reflection around what death means, whether it's a failure versus an inevitable consequence. That was it trying to keep the person alive or trying to give them a good death? What was the goal here? That's an important point, and I think definitely deserves attention, as you've pointed out here. In terms of interdisciplinary teaching, you have to be. I think that it's very clear that needs to be, particularly for this area of work, at the heart of what we do. That said, what you want to be careful about is not to make kind of pablum. You don't want to make a sort of generic education product that is applicable to literally everybody, or you think doesn't contain anything unless it's relevant to everybody. Because the problem with that is that there are some specialized skills that are different for everybody. I think that working in the ICU environment, where we do a lot of interdisciplinary care, but important to understand that within that team, you have some common elements, but you have actually distinct elements as well. That the role of a physician in a family meeting will never be the same as the role of the nurse in and around that family meeting. That most of the meetings that I will attend, the nurse will be in attendance, but may play a very, very minor role during the actual time that I'm in the room. But their role prior to that meeting and their role after that meeting in terms of preparing families and patients for the meeting, and then following up afterwards and ensuring understanding, support, and other traditional and important nursing roles is key, right? So understanding when we say interdisciplinary education, what that actually means. And again, it was pointed out, I think, as we were setting up this topic that it originally was one single topic, and then was split into nurses, doctors, and everybody else. And unfortunately, there's just so much out there. So you're right. We have to understand interdisciplinary education as a concept, but recognizing that within that, it's not a one-size-fits-all approach. That there are actually distinct roles for everybody. Thank you.
Great. Thank you. I'll just ask one more question.
Please.
So if we look at the Ipsos survey, you've mentioned Canadians are asking for specialists, but the research that we have access to shows us that, that pyramidal model where if we build more capacity for primary care and basic skills for all, that it's actually shown to provide more benefit or fit into the reality of the constraints of our system. Do you have any suggestions as to how we can bridge that gap between what Canadians want and what research suggests and what practicalities will?
Well, and again,
dictate.
it speaks to, unfortunately, to some of the shortcomings, I think, with any type of survey methodology. And don't get me wrong, I do a lot of surveys, but when you ask people what they want, and pick from a list and check all that apply, what the lowest percentage that anybody got was 62% or something like that. We wanted everything on the list, like it literally was like an all-you-can-eat buffet. I think that it's important to understand, and it's important for population to understand, that end-of-life care is not the other, right? Within the medical culture, once somebody is palliative, that is the idea between a palliative care approach versus a palliative care referral. So it's still my problem. I'm just maybe treating the person differently, but it's still the same team. So thinking of it like, nobody would, if a family doctor sees somebody get hypertension, oh, you got hypertension, I better send you to a cardiologist. Well, that doesn't make any sense. Family doctors should be managing hypertension. And understanding that as we, within the medical culture, start to recognize that end-of-life care is everybody's business and doesn't necessarily have to be referred to the subspecialist, I think only then, once we in our medical culture accept that, can we expect the population to understand the same concept. But as long as every doctor immediately turfs death to someone else, we can't be surprised when the population does the same thing.
Karina.
Thank you for your presentation this morning. As a fellow leaper, I'll get right to it. I really appreciate, definitely can see recommendations to bring back to our panel discussion. But something that I really wanted to highlight, I appreciate that you talked about the hidden curriculum and the significant importance right now, I think, for who is emerging as the leaders and how is that getting demonstrated. But I think it's also really important that there's a hidden expectation as physicians on these palliative care teams, that there's a hidden notion of leadership there too. And while we're boasting and promoting lots of fantastic definitions about whole person care, I think it's really important that as leaders on those teams, I guess it come back to thinking about Jim's story yesterday. And how his family has been impacted deeply by Huntington's disease and multiple diagnoses. But I think as leaders in 2016 in palliative care, we really have to demonstrate that we really are pulling together as multidisciplinary teams, having great case management discussions. Are we losing these folks in the gaps? And I don't say that this becomes the physician issue, but I think most families would equate the physician as the leader in that team. Yeah. So how do you help promote what we're promoting as a definition?
I would say it's the same, the interdisciplinary model problem is the same problem as the palliative approach problem, is that it's we are sort of teaching it like everything else in medical education. Time for a seminar. But the core concept here around hidden curriculum is that the world isn't waiting for a better seminar. Right.
I agree.
You know, you have to be much more realistic, not you, but we have to be much more realistic from what we can expect from workshops, seminars, and lectures when they're going out there in the world and seeing it totally differently. So, I mean, I can write any number of things down about recommendations about interdisciplinary modeling of patient care. People have to see it.
Yes.
And so, to some degree, I think that, again, as you say, the physician does take the lead on that. It's the sort of first to one equals model, if you will. But, and that's because a lot of people do look to the physician as the leader. But I think that working in an environment, working often in an environment where there is a lot of interdisciplinary care, you will see that a lot of it has to do with personality. There are some very strong nursing members who are very good at, you know, sort of modeling and leading by example, even if they're not the leaders. You know, they're not the quote-unquote leaders of the group. And in doing so, and they're saying, so doctor, I was thinking this and this and this and this, what do you think? And by the time, you know, you'll see it sort of come into practice, that really the model is being led by somebody who isn't the leader. And I think that the same way that interdisciplinary care is a distributed responsibility, right? Like I should say interdisciplinary care has to become, or the responsibility for leading a model can actually be distributed among all the members of the team. And you know, lead by example. Doctors can follow.
Yes. Okay.
Is that fair? I'm sorry, I don't know that I have a simple answer to your question.
There is no simple answer. I just think that we need to, as we were deliberating last night and really talking about that, we see the fractures in our system. We see the gaps.
Yes.
Jim's story really eloquently drove that home yesterday. And I think it's really important as we're making recommendations that we, you know, we really are setting ourselves as leaders in Canadian society to really approach death and dying and to make this far more comfortable for all specialties.
But if I can flip it a bit on you, and I'm sorry to do this.
No,
but
this is great.
Let me flip it on you, because to some degree, like, you know, you're saying, but don't expect the doctors to take the lead. You know, this actually can be led by any number of people. And for example, in ICU care, I mean, you know, the palliative care leader, you know, Dame Cicely Saunders is not a doctor.
Right.
You know, some of the leaders in advancing integrated models of palliative care within the ICU, Margaret Campbell is a nurse working down in Detroit. You know, these are models that can be rolled out there. Like a leadership can come from many sources, and I think you need to identify within all communities who is the person who can take the lead on that, whether it's a social worker, could be a physician. And you would be surprised how willing physicians would be to go along with that model, but don't expect them to necessarily lead it. And it's, you know, I don't think we can put all the responsibility on the physician.
Nor am I saying that. I just think it's really important that we're helping to promote that what we're saying is actually translating into practice. So no, I appreciate this is not a simple answer, and it's not a designation of whose roles are doing what. It's how are we going to roll this out.
Good point. Yeah.
Thank you.
Doctor, I want to go to the analogy of the tea bag that you used where you're steeped and then you're done.
That's right.
A very wise person, smarter than me, said one time that people are like tea bags. You know their real strength when you put them in hot water. So I'm sure you've been in hot water during your career with all of the challenges that you have before you.
Yep.
I'd be interested in, after we've talked about the education, the training, the mentoring, what are the personal strategies that you have to be a strong palliative care doctor?
I think, and this speaks to issues of wellness, like Marissa was bringing up earlier, the idea of resilience, personal resilience, coping, and the doctor culture. I'm going to think off the top of my head when I answer this. I apologize. But I think a lot of us recognize that the physician culture tends to be a pretty macho culture sometimes. We don't actually have the space. In many cases, we don't feel like we have the space to express emotion, to express weakness, and to express doubt. Again, it speaks to leadership, and there are many situations, you know, if you sort of go to pieces emotionally in the middle of a cardiac arrest, the arrest is not going to go very well. And to some degree, you have to be the calm sheep in the room when all else is blowing up and there's flames. I think this is a key element of ongoing teaching, and as we change the framework of continuing professional development, as well as in postgraduate education, of incorporating elements of wellness and resilience, that will, I think, go a long way to making strong doctors. I think if I'm catching your question correctly.
Yes.
Thank you.
Thank you, Dr. Downar, for a really invigorating presentation.
Thanks, Karen.
I have a question for you. I think you talked a little bit about the need for all medical staff to improve their communication skills, but particularly around the area of palliative care, and how that's all physicians' responsibility. My question for you is, how do we actually carve out time for practicing physicians to do things like learner-centered deliberate practice to improve their communication skills, especially when they don't think maybe their communication skills need much improvement?
That's a great question, and if you can answer that question for me, please let me know. Again, like with all education and with everything else, it's how many therapists does it take to change a light bulb? One, but the light bulb has to want to change. If learners don't feel they have a problem, they're not going to be as invested in it. I find simulation can be very helpful in that sense, where people can get into an environment, and in most cases we've all had a family meeting blow up in our faces, so that we know that whatever our skill level is, it probably could be better. Simulation can be very helpful to give people that feedback. And again, it's not always about telling people that they did badly, because people at any skill level could be doing better. So even people who do well, I give feedback to and say, here, next time, try this. Take it to the next level, try this, try this. Take the good and bad out of it, but make it into, how do we take you wherever you are and make you better?
Thank you.
Penny, you looked like you wanted a question, but now you put down your hand. Do you want a question or not?
I do. I want to know if in the experiences that you are providing the med students with, that you include the family in the classes in some way.
Yeah.
Because if I have found with the work I've been doing as a patient family advisor that physicians are still allergic to patients when they're too close, and when they're too close to their practice decisions. And we really don't bite. I think what we really want to do is to help you learn what it is about our situation that's important to us.
Yeah.
And that changes the communication skill. It changes the environment for the conversation. And many times I think physicians are hell-bent for leather to get your information across to the family, so you're not hearing first what the family needs to tell you.
The Tell Ask model is definitely the one we teach, and we try to make sure that we're always asking before we're telling. And I really have nothing to add to what you said, except to point out that the organizers chose Jim to lead us off, and they did that for a reason. It's the family member input is powerful.
Any other questions from the jury? Fred, apparently not. Thank you.
Thank you, Don. That means that we have about 10 minutes left that we can devote to questions from this room. And I'd invite anyone who has a question to approach one of the microphones. We'll start with microphone number 2.
Hi, Chris.
Hi, pediatrician in the room. Among the resources you've provided the lay panel, do you have any specific pediatric resources that you've given them? Because I'd like to challenge the notion that we have enough resources. There are resources available in pediatrics, but they're not widely available, and I would like to think that the 15,000 children in Canada who would benefit from a palliative approach to care can also benefit.
This is usually the time where I make a joke like you could just take the adult material and shrink the font. But I think it's an important, I have no excuse, you're absolutely right. I did not put anywhere near enough attention specifically to palliative care as an issue, to pediatric palliative care as an issue, and you're absolutely right. There is, I think, not enough, I'm not as aware of material out there. I think there is not enough material out there for standardized pediatric palliative care curriculum. And as the subspecialty in pediatric palliative care is getting formed and hopefully getting off the ground soon, hopefully we can go a long way towards setting some formal curricula in that area. Thank you for pointing that out, Chris.
Thank you. The gentleman at microphone number 1.
Yeah, Rob Fainsinger,
Rob.
Palliative Care physician. Great presentation. I love to hear you speak. So maybe it's a function of my gray hair, but I sometimes wonder if we don't pay enough attention to the historical perspective when we look at the information. So just as an example, when in terms of palliative care resources, when I did my fellowship back a generation ago, we had one trainee for a year. That was me. Owen was asking me how many people we train now. probably close to 150 residents and medical students in an average year come through our program. That requires tremendous resources. So my question is, I wonder what we miss by not looking at where we've grown, how we've grown as a guide to how we can improve. Because it sometimes looks dismal when you look at what we have now, but if you look at where we come from, I'm a little bit more optimistic.
I thank you for that perspective, because I think that is important. We need to recognize better the successes that we've had, and I think it's important to point out that particularly among the leadership in the Canadian Society of Palliative Care Physicians, the number of people who have been leaders that have been in place for decades, really fighting the good fight to get where we are now, to the point where we can be on a national stage complaining instead of just on a local stage complaining. And I thank you for pointing that out, Robin.
Microphone number 2.
Hi, my name is Corny Welcome. I'm here with the Canadian Virtual Hospice, but I'm actually a family physician, trained palliative care physician, and a family physician in oncology in rural Manitoba. And so I speak to the aspect of the practicing physician. You noted that it was difficult to measure a level 4 Kirkpatrick outcome, and I wondered whether steps 1 to 3 are really all you need to get to level 4. I wondered whether, you mentioned things such as communication and medical culture, but I've called that attitude with a small a, and not kind of labeling it as a good attitude or a bad attitude, but an attitude towards looking after someone with a life-limiting advanced illness, maybe like that nurse who stopped at the edge of the room, kind of changing the attitude to the approach. So one of the things that I wonder is how do we create a sense of importance of palliative care education, ongoing education in attitude and in those practicing physicians, many of whom are colleagues and many of whom have improved over many years, but who I think we still need some improvement in. And this, we have ACLS courses that are mandatory to work in an ER department. We have obstetrics courses that are mandatory to work in obstetrics units. But we can walk into a medical ward and look after a palliative care patient without any further evidence that we have competence in doing that.
Yep. I think the big problem here is not a lack of workshops. And I don't think that's a question that's necessarily going to be answered by taking 10 hours of education in 4 years and turning it into 20 hours of education in 4 years. I think we all agree that that's alone is not going to be sufficient. This is a system-wide issue. We can drive practice and change attitudes in so many ways. So we hire people to stand around little alcohol hand washing stations with clipboards to see how often we're pressing that. And this is actually someone's full-time job to do this. And there's zero evidence that it actually impacts behavior in any way. It's been studied well and shown to be completely useless to do hand washing audits, but we still do them because it's an accreditation standard. We have a number of different platforms on which to push agendas that we feel are important. In Ontario, we have ECFA, where you're required as a hospital to publish your quality improvement projects and your balanced scorecards of metrics. So we did a study a couple of years ago. We downloaded every balanced scorecard for every hospital in Ontario and found that 4% were publishing and measuring anything to do with relevance to palliative care. So stakeholders in this room can start to look at these and saying, look, if this is what you care about, if what you care about is on this scorecard, then you need something for palliative care on this scorecard. You need to make an accreditation standard where someone's standing there with a clipboard making sure that you're addressing goals of care, or that someone's actually asked this person if they're in pain, instead of hovering around the hand wash station.
We have about 5 minutes remaining. I think if we're succinct, we can accommodate all 3 people at the microphones. Sir.
It's Jeff with a halo around his head.
Jeff Blackmore from the CMA. Thanks very much, James. Always enjoyed that. One of the things we're doing at the Canadian Medical Association is, we've had resolution after resolution at our annual general meeting about the need for enhanced access to palliative care education at all levels of the continuum of training for physicians. We are sort of one of the first out of the gate with a national educational module on assisted dying. And what we've tried to do is use that opportunity to introduce educational initiatives and education, not just around that issue, but around end-of-life care in general, including sort of palliative care and pain and symptom management. We recognize very clearly the distinction between palliative care and assisted dying. We're also starting to see a lot of interest at the medical school level in saying, how are we going to teach assisted dying at the undergraduate and postgraduate levels? How are we going to integrate that into the curriculum in a way that I've never seen conversations around how are we going to integrate palliative care into the curriculum? So while we recognize the distinction, I wonder if now's the time to use this wedge and this opportunity in history to say, okay, let's introduce education not just around assisted dying, but let's make that a broader conversation around end-of-life care, using this opportunity to enhance sort of that integration into the curriculum.
I think that's a key point here, and I think that if anybody's ever answering a question on the place of medical assistance in dying, and believe me, I answer a lot of questions on the place of medical assistance in dying in healthcare, it's to point out, it's a very simple answer. If you go to the places of the world where it is legal, widely practiced for generations, and very, very widely accepted as a practice, it amounts to a whopping 3% of all deaths. In Oregon, it amounts to 0.2%. So we can talk if you want. If you want to spend an hour talking about what we do for 0.2 to 2% of the population, how much time do you think we should spend on what we do for 98 to 99.8% of the population? Thanks, Jeff.
Thank you. Yes, sir.
Hi, my name's Dave, and I'm going to die someday.
Yeah. And you're also a Maple Leaf fan.
And I'm a Maple Leaf fan, so I understand grief quite extensively.
We understand loss. Yeah.
So you're talking about how do we introduce initiatives to change some of the practices. And the reality is in nursing school, medical school, and the question actually goes for nursing schools as well too, do we have questions on our national exams around palliative care? And I know on the LMCCs we have not. So we're working hard to try to get writers of questions on the LMCC exams to put questions on regarding this. Because nursing students, medical students, they want to pass, they want to graduate.
Doctors love to ace tests, so yeah, if you care about it, put it on the test.
So I see that as one piece of, ultimately a small piece of an initiative to try to make this more important for students who don't understand the complexity and the importance of trying to learn this material because they haven't been out in the real world yet. So unfortunately, sometimes you need that little bit of a stick, being an exam, to help force people into at least being present for the education and try to remember some of it because they are definitely going to need it and unfortunately don't realize it until they get out in the real world.
Yeah, thanks, Dave. That's a great point.
Okay, thank you. And final question before we take a break.
I'm Catherine Downar, National Director with Pallium Canada, and I thank you, James, for a very informative presentation and for identifying the work of LEAP, which is our Learning Essential Approaches to Palliative and End-of-Life Care, wrapping the palliative care approach around different professions and settings of care. And I just weaving through from many comments over the presentations from yesterday and today, and recognizing that as Jeff has said, trying to support and educate and care for the 99% of our population, very much appreciating the interprofessional nature of the physician presentation. And our LEAP programming has a consistent thread of training from carers to paramedics to healthcare practitioners across home, hospital, and community settings. And so we very much appreciate all who are in the room and who nationally have supported over the 8,000 that we were able to train in this past year. And I would very much promote, as you were saying, the re-energizing of the educating of future physicians in Canada work, because as was said yesterday with the global decline in our ranking in integration of palliative care, that this is a very key element that can improve that. And as well, the morning presentation on the compassionate community work internationally, we're very proud of significant work underway in Canada, examples in British Columbia and Ontario that will be highlighted. So I believe Canada's on a very fine track right now. And my last comment on interprofessional competencies, there was excellent work done earlier on in Switzerland, as well as Quebec, and more recently in Nova Scotia. They're compiling a framework of interprofessional capacities. So I just comments.
Thank you very much, Catherine.
Okay, thank you very much. Ladies and gentlemen, we're going to take a 20-minute break, so we'll convene at 11:10. Dr. Downar, thank you for a great presentation and a very spirited discussion with this audience.
Thank you very much, Fred.
Thank you.